Welcome to you medics. I really appreciate you all. Thank you all for the support you have given this channel so far. Thumbs up, and I really appreciate that. Continue to share our videos so we can build a community where we can share our ideas, have some discussions, and learn from each other. Use 5 seconds of your time to check your subscription button. If you have not subscribed, kindly subscribe. We've dealt with 3 videos so far, which includes chest X-ray reading and interpretation, primary survey, advanced trauma life support in emergency medicine, and clinical history taking. Check these videos out after watching. Let's move into today's discussion. Full blood count. Blood is a fluid connective tissue that constantly circulates around the body, allowing communication between tissues distant from each other. It transports oxygen, nutrients, hormones, clotting factors, protective substance, and others. Blood is composed of plasma, a clear straw-colored watery component, and in which are several different types of cells, such as red blood cells, white blood cells, and platelets suspended. Before blood analysis, about 3 ml of venous blood is taken and placed in EDTA bottle, purple top tube, which is an anticoagulant coated bottle. The bottle prevents blood clotting, thereby preserving the blood cells for analysis. The bottle is gently swirled back and forth to enhance mixing of the ethylene diamine tetraacetic acid with the blood and to prevent damage of the red blood cells. The sample is then analyzed by an automated cell counter that counts and analyzes the blood cells, providing information about the patient's blood cells. Full blood count interpretation. Full blood gives details about the cellular components of the blood, which are red blood cells, white blood cells, and platelets. A sample example of how the full blood count looks like. And the components we focus on are the red blood cells, or the red cell count, the hemoglobin, the hematocrit, the mean corpuscular volume, mean corpuscular hemoglobin, mean corpuscular hemoglobin concentration. And with the white blood cells, we focus on the white blood cells, neutrophils, lymphocytes, monocytes, eosinophils, and the basophils. And the platelets, we focus on the platelet count. Starting with the red blood cells. The red blood cells are also known as erythrocytes. They are the most abundant type of blood cells. They are biconcave in shape with no nucleus, which provides large surface area for gaseous exchange. Their main function is to transport oxygen to the tissues for use, and carbon dioxide from the body to the lungs for excretion. They are filled with millions of proteins called hemoglobin that helps in the transportation of oxygen. And an oxidized hemoglobin gives the reddened color of the red blood cells. Looking at the stages in the development of red blood cells, we have the pro-erythroblast, the erythroblast, which are further divided into 3 stages: the reticulocytes, Those are the non-nucleated immature red blood cells, and then the erythrocytes, which are the matured red cell. The HB on the full blood count, it is the amount of hemoglobin in whole blood. Hemoglobin is a protein within red blood cells which is composed of hem molecules and 4 subunits, the 2 alpha globins and the 2 beta globins. Hemoglobin transports oxygen and other molecules in the blood, and this is the most commonly used marker for anemia. It is expressed in grams per liter or grams per deciliter. For the range, hemoglobin in males, they have 13 to 18 grams per deciliter, and hemoglobin in females 11.5 to 16.5 grams per deciliter. The red cell count. The red cell count is the number of red cells per liter of blood. It is expressed as 10 to the power 12 cells per liter. In other words, trillion cells per liter. The normal values in males is 4.5 to 6.5 times 10 to the power 12 cells per liter, and in females 3.8 to 5.8 times 10 to the power 12 cells per liter, which means in every 1 liter of blood in males there are 4.5 to 6.5 trillion number of red blood cells. The red cell count is particularly useful in identifying polycythemia. HCT, the hematocrit, which is also known as packed cell volume. It is the percentage of blood that is made up of red blood cells. When the blood is centrifuged, we have the plasma, the Buffy code, which comprises the platelets and the white blood cells, and the hematocrit, that is the packed cell volume. The normal range in males, we have 40 to 54%, and in females 36 to 44%. The 3 parameters can be used to determine anemia or polycythemia. When there is an increase in any of the 3 parameters, that's the hematocrit, the red cell count, or the hemoglobin, we term it as polycythemia. There are 2 types of polycythemia: the absolute polycythemia and relative polycythemia. With absolute polycythemia, there is an increase in the number of red cell count, though there can be also an increase in the hemoglobin and the hematocrit level. This is as a result of conditions such as primary polycythemia, that's polycythemia vera, which is a genetic disorder causing overproduction of red blood cells. In polycythemia vera, there is genetic mutation. The mutated cells in the bone marrow become very sensitive to erythropoietin, leading to excessive stimulation of red blood cells production. Also, secondary polycythemia, which is as a result of other factors or conditions. At high altitude, the air pressure is lower, resulting in lower oxygen availability. So to compensate, the body adapts by increasing red blood cells production. That will compensate for the low oxygen levels. Also, in chronic hypoxia, in conditions such as COPD, that's chronic obstructive pulmonary disease, congenital heart disease, smoking, obstructive sleep apnea, the persistent low levels of oxygen in the blood, the chronic hypoxia, The kidneys detect the hypoxia and releases erythropoietin. Erythropoietin stimulates the bone marrow to produce more red blood cells. The red blood cells increases to compensate for low oxygen levels. And in family history, genetic predisposition can increase the risk of developing polycythemia, and also idiopathic polycythemia, where we don't know the cause. For relative polycythemia, it occurs when the blood volume or the plasma decreases, thereby concentrating the red blood cells and increasing hemoglobin and hematocrit levels. This is different from absolute polycythemia, where red blood cell production increases. Note that in relative polycythemia, there is no problem with the bone marrow or any condition that causes overproduction of the red blood cells. On full blood count, there will be increased hemoglobin and or hematocrit, but normal red cell count. The causes of relative polycythemia: dehydration. There is fluid loss leading to loss of plasma volume, and the red blood cells in the remaining plasma becomes concentrated. Then the concentration or the percentage of the red blood cells in the blood is increased. So in dehydration, there's increased hematocrit, but the red cell count remains normal. High use of diuretics. The medication causing excessive fluid loss. There's loss of plasma volume, leading to concentrated red cell, and so the percentage of red blood cells in the blood increases. Hence, there is an increased hematocrit levels, but the red cell count remains normal. Also, in albumin loss, conditions like nephrotic syndrome, the decreased protein and decreased osmotic pressure in the blood causes fluid to move from the blood to interstitial spaces. The fluid loss leads to concentrated red cell. We then talked about anemia. When there is decrease in any of the parameters, hematocrit, hemoglobin, or red cell count, but mainly when there is decrease in hemoglobin levels, that's anemia. Then you check the severity of anemia. Mild anemia tend to lower limit of normal. Moderate anemia 8 to less than 10. Severe anemia 6.5 to less than 8. Then life-threatening less than 6.5 grams per deciliter. The causes of anemia: anemia due to ineffective production of red blood cells, that's in iron deficiency, where the red raw materials for making hemoglobin are deficient. Also in folic acid and vitamin B12 deficiency, where the vitamins that promote maturation of the erythroblast are deficient. This leads to ineffective production of red blood cells. Also, when there is bone marrow failure, bone marrow is responsible for production of red blood cells, and when there is bone marrow failure, there will be ineffective or impaired production of the red blood cell. Anemia due to increased distraction, that's in hemolysis, severe malaria, sickle cell disease, GCSPD deficiency, and anemia due to blood loss, heavy menstruation, hemorrhoids, peptic ulcer, infestation, that's hookworm infestation, bilharzia, and that is when there is peptic ulcer perforations. So these values are used to check for anemia and polycythemia. So to know the causes of anemia, the RBC indices are used. That's why we have the MCV, the mean corpuscular volume. It is the average size of the red cell present in blood samples. It is measured in femtoliters, and its normal range is 80 to 100 femtoliters. For the MCH, they are the mean corpuscular hemoglobin. It is the average amount of hemoglobin per red blood cells. It is expressed in picograms per cell, and the normal range is 27 to 32 picograms per cell. It can be used to determine the chromicity or the color of the red blood cells. However, MCHC is a more sensitive indicator for chronicity than MCH. MCHC, average concentration of hemoglobin in a given volume of blood. The oxidized hemoglobin gives reddened color of the blood. So how concentrated or reddened the hemoglobin is in that volume of blood, and the normal values are 300 to 350 grams per liter. So for macrocytic hypochromic anemia, there is low HB with low MCV and low MCHC or low MCH. The materials used in production of hemoglobin is insufficient or is impaired. In other words, there is a problem with the globins, hem or the hemoglobin synthesis, thereby leading to a macrocytic red cell. The causes of macrocytic hypochromic anemia, and the mnemonic used is TALES. We have thalassemia. There is a defect in the synthesis of globin chain of the hemoglobin. We have anemia of chronic disease. It is more in pneumocytic but can also be seen in macrocytic. Iron deficiency anemia or iron deficiency, deficiency of the raw materials used in making the hemoglobin. Lead poisoning, it impairs the absorption of iron that will be used in making hemoglobin. And sideroblastic anemia, it impairs hem formation. For pneumocytic pneumochromic anemia, there is low HB, but the MCV and the MCHC or MCH remains normal. It occurs when there is hemolysis or blood loss. That's in acute blood loss, anemia of chronic disease, hemolytic anemia, hemoglobinopathies, hypersplenism, which leads to increased sequestration or increased clearance of the worn out red blood cells, and also increased destruction of the red blood cells, thereby causing anemia. Macrocytic anemia, there is a delayed cell division and abnormal cell growth. The cells become larger than normal. And the causes, we have megaloblastic anemia. There is impaired DNA synthesis, vitamin B12 deficiency, folate deficiency. And the non-megaloblastic anemia causes other than the ones that impair DNA synthesis, that's alcoholism, chronic liver disease, hypothyroidism. When interpreting red blood cells, consider the hemoglobin content, whether it is anemia or polycythemia. If anemia, determine the severity of anemia and the possible cause of the anemia using the MCV and the MCHC. If polycythemia, determine whether it is absolute polycythemia or relative polycythemia. I hope this session was educative. Part 2 of this video will be created where we will talk about the white blood cells and the platelets. Kindly continue to support us by subscribing to our channel, sharing and liking our videos, and leaving your comments in the comment section.